Okay, so I promised to only mention the 2020 phrase of the year, COVID-19, 3 times during my presentation, and that was unfortunately one of them. So I'll be chatting about my journey through the past year and what it has meant to find some positivity in what has essentially been a challenging time for all healthcare workers, and how the past year can really teach us a lot about trauma prevention on the African continent. I'll be talking predominantly about a research project that we've been conducting over the last year at Tygerberg Trauma Center. The formal title of which is the effect of the COVID-19 national state of disaster lockdown on the trauma burden of a tertiary trauma center in the Western Cape of South Africa. A little bit about my background and a bit of context perhaps is I'm a healthcare worker, obviously, in an African setting, and have journeyed through various spheres of pre-hospital care, flight medicine, rural and district level care, and now placed in a tertiary center where I feel that I can enact change. Throughout my journey, patients have presented to trauma and emergency centers at various levels, and this has always sparked an interest in me and has got me thinking, how did this person get injured? Why did this happen to them? And sometimes the same patients come back with different injuries. Were these injuries essentially preventable? So currently working at Tygerberg Hospital, we feel the pinch on a daily basis. There are first world expectations on the system, often with third world resources. And so in order to provide some form of distributive justice, we have to utilize these scarce resources very carefully to keep the ship going and to ensure that the ship is traveling in the right direction. The past few years have shown ever increasing pressure on the healthcare system, and testament to this has been the military presence that is becoming more and more required in our areas to maintain a sense of order within our societies. Last year, this was necessary during a period of gang violence, which was ravaging local communities in the Western Cape. And this year, the military is also being called in to assist with policing and enforcement of lockdown rules. Does this presence and these heightened levels of enforcement, along with legislated change, answer the call of these communities? Can it have an effect on the burdens of trauma within South Africa? So to place some context into all of this, when I talk about legislated change, well, what do I mean? Well, following the first case of COVID-19 in South Africa in early March, the South African government took early and decisive action to safeguard society and our healthcare system, and instituted strict lockdown rules, which removed a fair portion of citizens' freedom of movement. This also removed some of their access to certain vices. This was then eased and graduated over the past few months, as you can see on the timeline in front of you. The strictest period was from the 27th of March through to the end of May 2020, when President Cyril Ramaphosa enacted a level 5 lockdown and graduated it down to level 4 lockdown. This was a very well-defined time period with temporary legislated change and change in societal norms. It was basically a research protocol that was served to us by our very own government. So, moving forward, you'll see that the results were unbelievable. They were immediate. Emergency centers nationwide, and specifically trauma units, ran on dribbles of patients for weeks. It was felt amongst us all. It was a welcome relief after gearing up for the big C, and I don't mean cancer. It allowed healthcare centers to prepare and to empty out ICUs and to allow for extra capacity for unwell medical patients. It was all very surreal, but it was daunting, and we all knew what lay ahead. One can see that the immediate drop-off on the red line from about the 27th of March, these were cases per day through our unit compared to the blue line, which was 2019. Thereafter, there has been a slow and steady increase in cases with predictable spikes over weekends, which you can see clearly on the graphs, and the dreaded month-end weekends where wages and salaries are paid, enabling people to indulge in their vices. Comparatively to last year, where no lockdown was in effect, you can see these clear spikes at the end of the weeks. This led us to ask, what did these legislated interventions mean for healthcare systems and for trauma prevention within our setting? Well, it was strongly felt that changes in access to alcohol, cigarettes, as well as freedom of movement limited people's disinhibition and access to vices. Workforces were asked to stay home, there was less commuting and less travel, people were interacting with each other less, they weren't allowed out of their homes, and if they were found out in public without a valid excuse, there were consequences. It was a nationwide social intervention that South Africa had never seen before, and it was truly an unprecedented time period to do research. As investigators, we wanted to know what changed during this period of time, and how could we use this data to empower future trauma prevention and, in essence, prevent unnecessary mortality and morbidity. Data was collected from clinical sources from 2019 and 2020 over a 3-month period, namely March to May. Multiple variables have been analyzed, including patient demographics, referral areas, mechanisms of injury, as well as the injury sites on the body, the days of the weeks when the injury occurred, as well as whether that injury was an intentional or accidental injury. Over the combined 6-month study period, over 20,000 data points with the above variables have been captured, giving us some very interesting information. So, clearly, an April to May comparison between 2019 and 2020 showed a rapid drop-off and major difference between the two caseloads of the different years. The intention of the study was to determine what the effects of the lockdown would be on our trauma burden. However, there were many preliminary and exciting secondary findings which I'm going to share with you today. Of course, the predictable decline in daily case numbers is evident, but it's when we start analyzing and cross-tabulating the variables with each other that we start to see some very important trends in injury patterns. These patterns and significant findings are what we should be utilizing to drive our trauma prevention strategies. Of course, the data is preliminary and analysis of certain variables is still ongoing. By simply looking at the demographics of the patients presenting to the unit, we start to realize common trends. I must mention that when it comes to demographics, there was no significant difference between the data pool of 2019 and 2020. Ages were not normally distributed through both years, and this was largely attributed to the high proportion of patients between the ages of 18 to 35. Similarly, with gender, males formed more than 3/4 of the patients presenting to our trauma unit over the combined 6 months. Already from this, we derive the stereotypical trauma patient, a young adult male. This is something to try and understand a little bit more when it comes to trauma prevention. Why is that so, and how do we prevent this? We know what we need to focus on in young men. Perhaps prevention strategies at school leaving or induction into workforces can be utilized. The ideas are endless, and this sort of data should be driving us to develop these strategies. Perhaps the most surprising result from the preliminary data was that of the analysis of the injury intent. I grouped various mechanisms of injuries into intentional harm or accidental harm. An example of intentional harm was that of an assault with a knife causing penetrating injury. An example of accidental harm was that of a fall or a motor vehicle accident. The reason that this was done was to assess the motive and intent that led to the patient's injury. Surprisingly, between the 2 years, there was an expected drop in all-cause presentation to the unit. However, the proportion of intentional versus accidental harm showed no significant change. The weighted mean of the 2 years is displayed on the slide. Although this was an interesting result, it does show us that there's definite benefit from targeting trauma prevention strategies to reduce intentional and accidental harm. If we go back to our biggest culprits that we spoke about earlier, the young adult males, we look at the various mechanisms of injury in the intentional harm category. We can see they form not only the largest subgroup presenting to the trauma unit, but are also the victims of a disproportionately large number of intentional injuries. Sorry, but even my presentation software doesn't believe in guns, so excuse the lack of gun icon. Instead, we've got a crossbow. Remembering that these are young, mostly healthy men who in an upper middle income country form a significant proportion of our workforce. The injuries in this population have ripple effects on the economy throughout not only their costs of care, but also their reduced contribution to our economy, reduced ability to provide for their families, and in many cases, long-term reliance on disability grants and state social services. It is really imperative that we as a community produce strategies to reduce the incidence of trauma in this population if we want to pull people out of these poverty cycles that perpetuate the trauma. Further analysis of the percentage of patients presenting on a specific day of the week for trauma cases was not significantly different between the 2 years. However, what was consistent and what was worrying was that even during lockdown, when there were spikes of patients over weekends, these patients consistently presented over weekends with more intentional injuries than accidental harm. What I mean by this is that the further subgroup analysis of injuries of intent per day of the week showed an alarming trend regardless of whether a lockdown was in effect or not. This alarming finding was the reversal of injury intent over weekends regardless of lockdown effect, whether it was last year or this year. We as a society need to figure out how we prevent this. Trauma prevention strategies could include boosting visible police presence in higher risk areas, stricter alcohol access and consumption laws over weekends specifically. And although the data analysis is ongoing, preliminary findings show certain referral areas are hotspots which could be targeted for these campaigns. If there's one thing that can be earned from this research and understood amongst us as a group of clinicians and as healthcare workers, it's that emergency medicine and pre-hospital providers really are at the coalface of the trauma pandemic within Africa. We need to guard ourselves and our resources to provide the best care that we can under our resource-limited settings. By engaging with public health specialists, policymakers, and industry, we must be able to reach a compromise and formulate a plan to reduce the unnecessary harm and loss of life and otherwise healthy patients. As a community, we are innovative, and I'm sure everyone will agree we're very tenacious. These are characteristics that will hold us steady as we go forward in improving emergency care in Africa. So to end off, we really need to lobby for change from authorities, our decision makers, and our governments. We need to provide efficacious interventions, and we need to make this relatable to the public so that they understand the need for change. Improving socioeconomic circumstances will help uplift and pull people out of this vicious cycle. We as a community need to empower research, but also we need to research for empowerment. We need to understand that as a pre-hospital provider or an emergency medicine specialist, public health is not only a large part of our work, but it also has drastic effects on our work. Thank you for your time.